Well, good morning and thank you. There are copies of the article. We are continuing on where we left off from yesterday on the topics, and there is going to be a worksheet that we're going to give out a bit. So this is EBM time. Thank you, Dr. Sharif. There is also the documents can be downloaded that we've given out, so if you wanted to go over the topic again, then the answers are built into the presentation as well. So today I'd like to go on, and we looked, this is day 4, but today we're going to cover the second and third phases of critical appraisal. We're going to explain relative risk reduction, where you're going to be able to describe absolute risk reduction, and you're going to get to use and be able to talk about the number needed to treat. So we're going to do that this morning by quickly just reviewing what we've done over the past 3 days in about a minute, and then we're going to look at the critical appraisal article. We're going to push on to the importance of the results and applicability. So on day 1, we started and we looked at questions and what questions were. We described background questions, and remember those are the W5 questions: who, what, where, when, why, how, and then the disease or the condition of interest. And then we moved into the clinical-based questions, a well-built clinical question that we used over here on PICOS. So the patient, the problem, the population, the intervention, the comparison intervention, the outcome of interest, and the study design. So that was day 1. In day 2, we pushed into finding the evidence. We looked and defined what quality filtered literature was and gave some ideas of sites where you could go get that information. We specifically looked at PubMed clinical queries, using that as a quick search engine to find quality literature. We looked at TRIP database, clinical evidence, and I believe if you are or have a subscription to the BMJ, you can access clinical evidence. And the last one we looked at was Google Scholar. And I think I might have had the URL incorrect, but it is www.scholar.google.com, and there is an Egyptian website for that. So I believe it defaults out to the Egyptian Google Scholar. So yesterday we went through validity, and I'm just going to put on the next slide what our summaries were. So remember, I've divided these into 2 groups because when you look at that worksheet that we had, it was divided into 2 big boxes. The first box looks at the how can bias enter your study. So how can that study that's going on deviate away from the truth of the of what the population you're being looked at? And we said in the study we looked at that we felt the patients were randomized, so we gave it a check mark. We couldn't really tell if the randomization was concealed or hidden, so we put a question mark there. There were patients analyzed in the groups to which they were randomized. Remember, that's the intention to treat principle, and we gave that a check mark. And we said, were patients in the treatment and control group similar with respect to known prognostic variables? And that was information that we gleaned from table 2, and we felt, yes, they were, that prognostically they were equal. So we said in the selection bias, we were quite happy with how the patients had been selected to participate in the study. Then we looked at the next big area of bias, or how the study could deviate from the truth, and we called these measurement biases. And we said we weren't really happy that the patients were, we felt the patients could be aware of which group they were assigned to, whether or not they got Erwinia or whether or not they got E. coli L-asparaginase. We felt that the clinicians would clearly know what the patients got because they were ordering it. And we felt that people who were looking at the outcomes, the event-free survival, the response rate, could easily know what the patient got. So we felt that there could be, that in this study, the way the study was conducted, that there could be bias that came into the study. Not necessarily the bias actually entered the study, but it had a potential of being there. And the last thing we did, we said, was follow-up complete? And I think somebody noted on this side that there were 18 patients missing out of about 700. And we felt, and we said that as long as that 80% of patients who started the trial remained in the trial, we'd be quite happy because we knew the statistics would surpass what was needed. So we felt overall in the measurement biases that there were some deviations that could let bias come into the study, but we accepted that that's how we conduct clinical trials. And we did feel the follow-up was quite complete. And overall, I think we scored somewhere about 7 to 8 out of 10 on the quality of the study. So today we're going to move into the last two boxes on the worksheet, the importance of the results and the applicability. And remember I said it was validity, importance of results, and applicability, and that was VIA, and the reason I use that is because our train system in Canada is called VIA Rail, and it was a way for me to remember on the spot when I'm reading an article how I need to critically appraise it. So we're going to first look at the importance of the results, the second box, the third box on the first page, and we're going to go through that in reference to the article we did. So we need to look at some of the measures of the trials. So the question really, when we're looking at the importance of the results, are these results important enough that you really should be impressed by this article? You've already gone through the validity. You said it's a reasonably well done article. You feel comfortable that you're now going to expend the time looking at the results because of the way the study was conducted. So we have decided we're going to read this article. We're not going to chuck it. We're not going to throw it in the garbage can because we gave it a 1 out of 10. We're happy that maybe this information will help us change practice. Well, there's different ways we measure results. There's a relative risk, which is just the ratio of something called the number of people in the experimental group that had the outcome of interest. So in this study, when we look at that, we're going to call that event-free survival. So we're going to look at the number of people in the experimental group that survived as a fraction, as a frequency, so a percentage, and we're going to compare that to just what happens in the people who got E. coli, our controls or our standard rate of treatment. So we're just going to put one over the other, the experimental rate over the control event rate. So that's relative risk. Then there's something called relative risk reduction. And the relative risk reduction is something you see much more in clinical trials. And it's a percent reduction in the events. And what we do here is we actually are just standardizing it for the baseline. So we're looking at what are the number of events that occur in our control group, and then we're going to look at the difference between the control group. So a subtraction on the top, all divided by this baseline, the control event rate. I'm just saying this because we're going to reinforce this as we go through the article. The other measures of therapy that you need to know about are something called the absolute risk reduction. This is a straight subtraction of the number of events that occur in the control group, subtracting what we see in the experimental group, and that difference in the number of events is what we're concerned about. So we'll look at that and how that's relevant, and then we're going to look at something called the number needed to treat. And you may have heard of this, but this is the number of patients that we would need to treat with this treatment to see one less event. And we're going to come back to this. The first three of these are actually in the results section. The number needed to treat actually comes under applicability. And as you see, when we go through the number needed to treat, it has a lot of preferences and may have patient values in it. It may have physician values in it. It may have society's values in it on what sort of number needed to treat you would accept. And that's part of where evidence-based medicine is part of responsive to the population, responsive to people. And we'll come back and we'll talk about that as we go through to this morning. So on the worksheet, there's two boxes at the bottom under the results section, And there was how large was the treatment effect, what was the relative risk and the absolute risk reduction, and I talked about those. And then how precise was the estimate around that. So as we go through these results and look for the importance of the results, we have to define first what is the primary outcome that these study people decided. So if you go into the methods section, and towards the end of the methods section, they say the primary endpoint was the event-free survival. Now they're reporting a complete a CR at a lot, and they do use that to calculate this event-free survival, but that's the primary endpoint. So I encourage you, when you are thinking about the article, to check what the primary endpoint is. A lot of times in studies, not because of maliciousness, but because people are writing studies and they ask people to review it, and people don't know some of the critical appraisal techniques. And again, as I explained yesterday, one of the benefits of doing this is that if you are asked to review a clinical trial or an article for literature, you can use these skills to be the most help to the editor of the journal. So we're going to say this is the primary outcome. And then if you go down into the results section, I went looking, what I did is I searched for the event-free survival as the primary outcome. And then just in Adobe, while I had the document open, I typed into the search feature and I said, find me other words where event-free survival comes up. And the next one where it comes up is actually in the results section, and it actually gives me the results here. It says the rates they're talking about was shorter in the Erwinia asparaginase arm, figure 1a. Its rate at 6 years was 59.8%. So they're talking here about Erwinia versus 73.4 for the E. coli. And then they talk about estimated hazard ratios for remission, failure, relapse, or death. Interesting, but not entirely helpful for us to understand this article. What happens here, and this is where people get quite worried about the articles, they say, oh, I've got to understand statistics and what hazard ratios are, and I don't understand how they did this. But these are just adjustment techniques, and if you're doing this, you're using a complex statistical program. I'm going to show you how to do the numbers with just some numeracy, not statistics, and get the results and understand what's happening in the trial. So where I want you to focus is this is figure 1, and I think it's on the 3rd or 4th page of the article, because this is where we're going to extract the information, 2nd page of the article, and 3rd, sorry. And this is where we're going to take the numbers from. So I'm just going to hone in on the slide to show some of the numbers. So at the bottom in the descriptor of this figure, there is, it says the solid line belongs to the E. coli L-asparaginase, and the dotted line belongs to the Erwinia L-asparaginase. And they found this number, this percentage of events at this time. And here I'm just checking the numbers that we saw from before. These numbers add up to 700. It's what was stated in the article. So the first assumption I'm going to make is that we're going to use an intention to treat analysis. So I don't care if people fell out. I know from reading the article in the validity section that the numbers are small of people we lost. So I'm going to accept that those numbers are small enough that they're not going to affect how I'm going to interpret the results. So this is the famous 2x2 table. It scares students, it scares people writing exams, but there are some basic foundations which you should do when you're thinking about a 2x2 table. And people who write articles violate them all the time. But go back to PICO, patient, intervention, comparison, intervention, and outcome. The patients are going to go in the boxes. The outcome is always on top. And one of the ways one of my colleagues says is to remember the outcome is the truth, and the truth comes from above. So you should always look above for what the truth is. This is the intervention. This is under the human's control, so it's not the truth. It's not high up there. It's on the side. And so the intervention, the standard intervention and the experimental intervention are here. So here's the truth. I changed this, it should read event-free survival versus event-free survival that didn't happen. And we're going to work through this table as we go on. So thinking about the numbers from that figure, this is what the table would look like. And these are the numbers I'm going to calculate. So the first thing I did is I determined what number of people got E. coli L-asparaginase and what number of people got Erwinia. And that's in the table, it's in several of the tables, it's in the document, it's on that figure. And I just put the numbers on the side and I add them up on the bottom to make sure they add up to the number they're supposed to. Then I'm concerned about the event-free survival. So they did give me a fraction. And so all I did was multiply that percentage times the total to get a number that fits in that box. And it's 260. So did people see, I got the number, it was 73.4% from the figure, and I just multiplied it by the number of people that were in that arm. And that fits into that box there. That's the number of people who had event-free survival, because they told me it was 73.4%, and I just wanted to convert it to the number, that number of people that were participating in the E. coli arm. So that was 260. It's actually by multiplication. There's been some rounding, but they work out to 259.9987 or something. So I presume they really meant 260. And then I just do straight subtraction to fill out the people that didn't have event-free survival. And that was 94. I did a similar thing taking the 59.598 and multiplying that by 346 and getting that number, 207. Did some simple subtraction again and ended up with 139. And then I just add up my numbers and check that these add up to 700 so that everything balances out and I haven't made a mathematical error. So remember, I put the outcome on the top and I have the interventions on the side, because as the experimenter, I'm looking across the table, but the truth is coming from above. So then these are the event rates, these numbers here. So control is for C. So what did I decide was the standard of treatment? Well, that's E. coli L-asparaginase. And what was the experimental? Erwinia. So I'm going to calculate an event rate, or I'm going to calculate a frequency of events. What numbers would I use for that, for if I was using the control and the control was L-asparaginase? Where would I get those numbers from? Yes, so what numbers would I choose here? Yep, and put it over 354 to make a frequency. Lo and behold, I just did all the math to convert that number out this way when they told me it was 73.6%. That's exactly what this is going to work out to. So let's just do the math. So 73.4, and I converted into a decimal versus a percentage. So I've done all this work to show you how to fill in the table, but actually the way the article was written and the abstract, the article's written, you could actually make the calculations without having to go through all the math steps. But I did want to spend a second setting up the 2x2 table for you to understand that. Similarly, for the Erwinia, the experimental drug in this situation, I just took 207 over 346, and lo and behold, is the exact percentage that I started with at the beginning. So that helps me understand that a lot of times the studies will give you the percentage and you don't have to do a 2x2 table. You just have to figure out what the control drug is, what the experimental drug is, what is the frequency of events, and you can do all the rest of these calculations at that time. So these are the calculations that I talked. Remember I said this is a risk ratio, so it's just the ratio of the risk of developing that in the experimental group versus the risk in the control group, the baseline. And this is the relative risk reduction, so all I want to find is a reduction. What is the reduction in the risk? And put it over the baseline. And this is an absolute risk reduction, so I just want to get the absolute difference between the two, and I don't want to standardize it towards a baseline. And we'll go through those numbers, and then we're going to have an opportunity to work through a worksheet to try it again. So the risk reduction is 0.81. So I just took the ratio of the experimental group over that, and that works out to 0.81. The relative risk reduction is the subtraction of this over the baseline, which is 0.9. Now notice how these numbers add up to 100, because that's the risk reduction is the relative risk reduction is just one minus the risk reduction. So it always adds up to 100. So if you're doing these two, that helps. The risk reduction is not as clinically relevant unless you're concerned about the ratios, but the relative risk reduction is what you'll see a lot in articles. We're going to talk about that in a second. Well, the absolute risk reduction, lo and behold, is going to be these numbers here as an absolute difference between the two. What did I start the baseline group get, and what did the experimental group get, and what's the difference between those two groups? And that works out, I just added a decimal for completeness sake, because we're going to do some more math with this later on, but it's 13% or 13.6%. So that brings up to the question, I'm going to say the number needed to treat as well is just 1 over this absolute risk reduction, and it's going to be 7.4. Now I'm going to talk about these numbers in a second, but let's go here. So these are the numbers that we had, and the relative risk reduction is the percent reduction in the events comparing the two. So that's here. And then we talked about the absolute to reinforce that. And now I want to move on to units of measure. Vivian, that other copy of the sheet, please, if you could hand that out, yes. Vivian's going to hand out a one-page sheet. It's double-sided. The first side is actually just some definitions to help you. This will also be posted on the website. Dr. Ahmed has told me, so I gave him this. But we're going to use the second side of the page where there's a cartoon, a picture, and we're going to do some numbers. And we're going to work through the numbers together. And this is just to show the relationship between the relative risk, the risk reduction, the absolute risk reduction, and the number needed to treat. And then we will talk about what those numbers mean. So you'll notice on the side with the bar graph on it, there is a little table at the bottom, and that's what we're going to work through in the next few minutes. There are no wrong answers, and this is a learning exercise, and you'll start to notice there's a bit of a pattern as we work through this. So here's the picture. So I'm doing 3 different experiments, and this is what I find in one study. And then I find this in another study, and then a drug company did a study and they found this number. Okay? So out of a total 100 patients, 80 of them had, the control group had the response, and in the experimental group it was 40. In the second time when a friend of mine did it, they had 8 out of 100 or 4 out of 100, and when the drug company did it, they got 0.8 and 0.4. So if you look at the table at the bottom, we're just going to calculate. Now remember I said the control event rate was just the ratio between the number of events and the total number of people that participated. So what would that number be as a decimal? Or even 80 over 100. So, yeah. Pardon? 80 over 100? Because there's 100 people in the study and we had 80 of them. And in the experimental group, 40 of them had that over the 100 that were in the group total. Because there was 100, we randomized the study and there was 100 in each arm. So we convert these to decimals and we get 0.8 and 0.4. Now what would happen with this group here? How many events would we have in test 2? 8 over 100 and 4 over 100, or 0.08 and 0.04. And what about when the drug company did it? 0.8 events, 0.4, that would be 0.008 over 0.0 and 0.004. So we did that, and that's what we got. Now let's calculate the relative risk reduction. So when you put 0.4 over 0.8, that becomes 1/2, which is 0.5. When you put 0.04 over 0.08, you get 0.5. And when you do that, you get it again. So for the relative risk reduction, all these studies showed the same relative risk reduction. All these studies were similar. And the drug company comes out and it tells you, if you use our new wonder drug, you'll get a 50% reduction. But are they talking about the study I did, where it was quite big, like 80 patients out of 100 over 40? Or were they talking about my friend who did the study and got 8 over 104? Or were they talking about the study they did where you can barely even tell there's a difference between the two, but they're telling me it's a 50% reduction? So it really depends which one you're looking at. They all have 50% relative risk reduction. They're all wonderful, but they're all very different when you look at them. So one of the things to do is to look at the absolute risk reduction. And here again, you're going to get subtraction 0.4, 0.04, and 0.004. So although the relative risk reduction is similar, the absolute risk reduction goes from a great 0.4 or 40% down to less than 1%. Which one should I trust? And how do I explain that to my patients, or how do I explain that to my colleagues? Well, one of the ways to do that is to look at the number needed to treat. And it's just the inverse of these numbers. So what is 1 over 0.4? 1/4 with a decimal moved. So 2.5? What would this one be? 25? And this one? 50. And that's what happened. So although I have all the studies showed, the one done by me, the one done by my friend, and the one done by the drug company, all show a 50% reduction, the absolute risk reduction really depends on where I started from. My study showed a phenomenal risk. I would sign my patients up if it was a well-controlled trial. But here I might have a bit of difficulty. And this is where the number needed to treat comes in. And the number needed to treat, as I'm going to show you right now, really depends on our values. And I might say this is treating or curing childhood cancer, or this is treating an infection, otitis media, and which number needed to treat I would accept will be quite different. Now, what does the number needed to treat, and how do you say it? Again, I come back to PICO. So among patients who received treatment A, I would need to treat 80 patients with I would need to treat 2.5, or we're going to call it 3 patients, with treatment A to see 1 patient get better, let me take this back to PICO because it'll help you. I would need to treat 3 patients with treatment A compared to 3 patients with treatment B to see, I would need to treat 3 patients with treatment A to see 1 patient get better with treatment A over treatment B. So I said the patient, I said the intervention, I can say the comparison intervention and the outcome of interest. So I haven't defined what the outcome. Or I would need to treat 25 patients with treatment A compared to treatment B to see 1 patient get better. Or I would need to treat, in the drug company's trial, I'd need to treat 250 of those patients to see 1 patient get better. Do people see the difference? Is there questions? Or? Okay. So, using those numbers, we're going to work through the article in a second and come back and talk about those. But when we're looking about absolute and relative risk reduction, we're looking at the effects from therapeutic trials, and the difference in the risk is what we're concerned about. So going back to these numbers, I didn't have the opportunity to calculate the confidence intervals, but I'm going to say we'll come to that when we do another session. The computer internet was down, so I couldn't get access to the website. But what happens is the importance of the results. We said we needed 7.5, or we're going to round that up to 8 patients. So I need to treat 8 patients with E. coli L-asparaginase compared to Erwinia L-asparaginase to see 1 improved event-free survival, is how we're going to look at it. But one of the things that also happens is we get confidence intervals and p-values. And I'm going to reinforce this in a session again next week when we go through this. But the confidence intervals are a range around where your number needed to treat flows. And on this one, I think it worked out when I did it by basic math from 2 to, I think, 50. So I could have I would need to treat as few as 2 patients to see 1 patient get better, 1 more event-free survival, I would need to treat as many as 50 patients to see one. And the p-value was statistically significant as well. But I'm going to come back to that. So confidence intervals are helpful because they give you a visual idea and a range. And this confidence interval is just is easiest to understand when you talk about how things are distributed. These are standard deviations from the side, and 95% falls in from here, from about just around -2 to +2 around the distribution. The reason the confidence interval is important is it gives us an idea of the precision. And the precision means, remember yesterday when we're shooting the arrow and we're trying to hit the target? And we're trying to hit the truth in the center? And when we hit the truth, then the study is valid. But now we're talking about the concept of precision. And we may shoot those arrows and get the picture where there's a conglomeration of arrows, but they're not on the truth. It's very precise, but it's not truthful. So there's two different concepts here. There's validity, and then there's precision. Or I may have that clump of arrows right on the target, and then I have a study that is both valid and precise. Or I may have those arrows distributed all over the target unequally, and that's neither precise nor valid. Or I may have them distributed in a more tight format in a certain area where they are precise but not valid. The confidence interval you can calculate, but there is a website which I'll show you next week when the internet's a bit better, and we'll show how quickly it is to do that. And there's computer programs out there that will do this simply for you. As long as you set up the 2x2 table correctly, you can pump those numbers in, and I'll show that by slides next week. So what? Well, I'm going to pass this one and come back. We do anchor everything on this shrine of statistics of 0.05, but a p-value of 0.05 is an arbitrary decision which people have decided to accept as the standard. And it's hard to convey that when you're looking at it visual. We know that a p-value of 0.00005 is much stronger, but there's still a chance of random bias entering. So we do put a lot on it, but probably confidence intervals are more helpful. So a probability level, it's the likelihood between the difference between observed interventions that it could have risen by chance alone or random bias. And we arbitrarily set it at 5%. So we're going to go through the applicability, the last page now. And does the patient match, does a patient here at your hospital match the inclusion criteria of the study? So if you go back to the very beginning of the study, these were patients from across Europe who have childhood leukemia, who needed treatment. And do we have any reason to believe that pre-B cell ALL is different in Egypt from Belgium, from Canada? Not really. So I would accept that the patients were similar. And I don't really think there's any compelling reasons that this study should not apply to the patients I'm looking after who have childhood leukemia. Were the primary and secondary endpoints of the study? Well, we said we're concerned mostly of the primary endpoint, and that was event-free survival. There were some secondary ones in there, and they didn't use surrogate endpoints. They're actually the one that's important to us is whether or not you're alive or dead afterwards. So there is truly no surrogate. They may have a surrogate endpoint. An example would be if you did a blood test that you could take at the very end of treatment, and that test may be a rough measure of whether or not you're going to live or survive. So maybe a MRD may be helpful in the time. It may be a surrogate endpoint that people are looking at. But it's the truth. What we really want to know is whether or not you're dead or alive after you've completed the study. And then lastly, notice that the number needed to treat is in the applicability section. Because I said where it was 2.5, 25, or 250, it makes a difference on which drug we're using, which treatment it is it primary ALL, is it relapsed ALL, is it relapsed ALL after a bone marrow transplant? I'm going to have different degrees of acceptance of number needed to treat. And then importantly, the last question is the reduction in the clinical endpoint worth the cost and risks? So we talked about that, we said that. And so, as I mentioned, we round that up to 8. And again, here is probably better than when I try to use my tongue to say things. Among children with ALL, I would need to treat 8 children with E. coli L-asparaginase compared to Erwinia to see 1 more event-free survival. Now, for people, is that helpful? Is that number helpful? Is that going to change your practice if you were thinking of using Erwinia as frontline versus E. coli? Would you feel more convinced that if the drugs are very similar, that there'd be an increased chance of survival? No? Okay. Because the conclusion, and that's your choice. E. coli is the standard, it has stayed the standard, and people felt, and the conclusion of this study was they felt that they would stay with Erwinia, with E. coli, and not change over to Erwinia, because of there's 8 patients, you only need to treat 8. They considered that number small to see 1 improvement. And so they were really this was a type of study reinforcing that E. coli should be your frontline study. So it's not bad, but again, what you're doing here is perhaps if Erwinia was the other way around, and Erwinia you had to treat 8, you could argue that this would be a reasonable thing to do to switch patients over. What this study is doing is supporting, it just supports the standard of care. It's saying if you only need to treat 8 to see 1 improvement, and that's your standard of care, it's probably worthwhile doing. And that's one of the things that happens in the discussion of the article. Remember, though, as you're walking through this, that those patients, those values that you had at the end should what you'd be discussing. Because if you were discussing this in a management rounds, you've gone through the data, you found the information, and now it becomes your preference as a physician, your preference as a pharmacist, your preference as a patient, as a parent, of which one you want to accept. So you could say, in this situation, this study does support maintaining the standard of treatment using E. coli as the frontline drug. But remember, there may be situations where statistical significance is not the truth. The statistical significance is a requirement for determining whether something is clinically significant, but it's not enough. And the p-value tells us the risk of the difference between the 2 treatments was due to chance. But relative risk tells us part, but not all the story. And really, the number needed to treat helps us. A number needed to treat of 8 is probably most helpful. And I'm going to reinforce next week the confidence intervals and going over these numbers and working through them again. So far we have gone through step 1. We've done a will-built clinical question earlier in the week. We looked for the evidence on the second day, and over the past 2 days we've appraised a therapy article through the validity, through the importance of the results, and through the applicability. What I'd like to cover next week, and I'm just putting this up because I'm open to change this, but I thought we should probably look at systematic reviews since the Cochrane is such a force out there, and a group of us are trying to push the Children's Cancer Research Group of the Cochrane as well, and get more people involved. So you'll probably see more and more of children's studies coming through the Cochrane database. So if we can go over some of the basics of reading and understanding what a systematic review is and demystify it, that might be helpful. Then we could critically appraise one. I believe I'm doing this as Sunday. I was told I was doing Sunday, Wednesday, Thursday. Critically appraise a systematic review. And then here we could either look at a diagnostic test. I don't know if somebody has an article. One of the questions that I've heard many times is about CRP. It's a test I don't use. We could look that, or if there's a radiological or diagnostic imaging study, a GFR or something like that, we could see if we could find an article for that. Or we could do another therapy article. But I'll just leave that for discussion on the last one, and I'll adjust that as we go through next week, because I'd like to be most helpful to you. So was there any questions to you? Is there any questions on these numbers? Okay, so we talked at the beginning that we would go through the second and third phases, and we'd call this the importance of the results, and we'd call this the applicability section. We explained relative risk reduction, and we showed how you can have a 50% reduction, but that's in a rate, and it could be quite different going back to the bar graphs. Then we talked about the absolute risk reduction, which is just a straight subtraction. And then we calculated number needed to treat. In our study here that we critically appraised, it was 8. And you've got the examples of 2.5, 25, and 250. And you can explain that to patients and use that in explaining to families that the reason I'm using E. coli L-asparaginase is because for every 8 children I treat with E. coli, I get 1 better event than if I had used the Erwinia.